and now she is ready for the next one. Actually, from our intervals, she would be in 2 weeks, but she was, happy enough to come and show you how this works. And what I will do now is I will anesthetize her nose with the lidocaine 4%. She knows this procedure, and then the nasopharynx and the mesopharynx, and also some of those drops go into the larynx, but not enough. So I will introduce, like I showed this morning, the endoscope, the flexible endoscope with a working channel, and I will drip in about 1 cc more of this lidocaine 4%, and then we will do the injection into both ventricular folds. Some of the patients say from the whole procedure, actually the nose introduction is what they don't like if they have discomfort. So let me have a look how the larynx looks like. I like to have the head a little bit up. That's very nice.
So you go always through the right nose, yeah?
Right or left, whatever is the better one.
Okay.
Okay, this time it's the left side, and you give me a long E. Okay, und nochmal lang einatmen. Und noch ganz lange. E. Now this is the strobe mode. And switch back. Okay. So this is now the aspect, and of course, before I do a new injection, I always look at our old recordings. I'm very nerdy. We're very nerdy about that, which means that we always record everything, every intervention, and it starts with the face of the patient. So just in case that we have a recording, we always want to identify the patients as well. So now I will introduce this single-use catheter again, and the anesthesia is a very important part, and I already asked her how was the last time and how should we go on this time. Should we go for the same dose or a little bit less? And today she decided it was a little bit too much last time, so that was Dysport 7 units per side. That means that I will now give her 5 units per side ventricular folds. So now I have to find a situation where we both are comfortable.
And Marcus, because we have a long catheter and you have a syringe in the back, how much do you have to have in your syringe to get the right volume?
The double dose that I expect to put in, and then I chase with saline.
Okay.
But it's not all the Botulinumtoxin. So you see, if she puts the head up, then I get more exposure, just to show you how the larynx moves. When I move the head, there's also a different angulation that comes with that. But I can also, move with the tip of the 4-way endoscope. So I always, that's my routine, start on the right side.
Marcus, can you explain what's the possible advantage of injecting the vestibular folds instead of vocal folds?
Yes, nasal holes. So the advantage of putting it into the ventricular folds is that the patients don't have breathy voice afterwards. So now Susanna injected 5 units, then I asked her to put the needle back, and now I turn the endoscope. You see this is rotation endoscopy. See what happens when I turn her head, then I have different exposure of the right and left side. So for this left injection, I want to come right from the back side. Needle out, I'm saying to Susanna, and then I put in the needle, and then she puts 5 in.
Okay.
Yeah, yes.
So we can see it really good. Good exposure.
Now it comes. Okay. Now it's good.
Marcus, we do it both, a rotation. I think it's a wonderful endoscopic procedure, especially also when you want to see if the vocal folds are in a different niveau, on a different level. You can see them very well. Also,
isn't it nice how nicely you can see also the Morgany's ventricle inside?
And the anterior commissure you can see very well.
And that side as well. And you can go anterior commissure also. And if you want the patient, tief einatmen. Take a deep breath and then they abduct. And you can also look nicely at so many aspects of the larynx. But you can also do that with the, let's say, normal vision. And that's why I like these levers, because then I can address even more, how to go in. Does that play a role? Yes, because what you can see here, what I can do is I can also palpate with the catheter. I can also palpate different areas of the vocal fold and the ventricular fold. So if there's a sulcus, I could palpate it and see if something's happening. And for the right vocal fold, I like it this way. For the left vocal fold, I would turn her head a little bit and then palpate this way. So the camera should be in the middle of the larynx while the instrument is coming from at my position here at 9 o'clock. But if I would hold it the other way like the Marseille group does, then it would be at 3 o'clock. I think we're done.
Marcus, your device has a suction channel, but you're not connecting any suction tube. Is it because, in my experience, it's because it's really like a huge weight on the endoscope, and it's not needed most of the time. You don't need.
Yes, you're totally right, Gauthier. If I have a suction tunnel, this is the suction over here, and we have a Y-shaped hosing system, and it goes up here. However, if you have the catheter inside, then there's no space for suction. But if you have the 400 micron glass fiber tube, then you can have suction as well as doing laser surgery.
Yeah. But isn't it too heavy at a certain point? Because you don't seem to need it. You don't seem to need it.
Yes. I sometimes I need it, but if you see how I hold this endoscope and the suction comes in here, then it is interfering a little bit with our system. But if you have the original suction device that you snap on, then it goes away on perpendicular, goes out to the side, and then it should work. So suction is available and sometimes useful, but in most cases, I would say 90% we don't need suction.
Fair enough.
Thank you, Marcus. Thank you. Great performance. Ja, vielen herzlichen Dank, dass Sie dabei waren und dass Sie das mitgemacht haben. Ja, ganz toll.
Cheers. Thank you.
So
See you later.